This episode is sponsored by PACS, the gold standard in emergency response bags. So when you're working under pressure, you need kit to be both dependable, tough and intuitive, and that's exactly what you get with PACS. Every bag is handcrafted by expert tailors who understand the demands of post-op care, from the high-tech, skin-friendly and environmentally responsible materials to the cutting-edge welding process that reduces seams and makes cleaning easier. PACS absolutely puts performance first. They've partnered with 3M to make perfect reflective surfaces for better visibility, and bright grey interior makes finding kit effortless and fast even in low light. With over 200 designs, PACS bags are made to suit your role, your needs and your environment. And thanks to their modular system, many bags work seamlessly together no matter the setup. PACS doesn't chase trends, their designs stay consistent, so once you know one, you know them all. And if your bag ever takes a beating, their in-house repair team will bring it back to life. PACS are built to perform, made to last. Learn more at pacs-bags.com or head to the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. I'm here again today with Radu Venter. He is a paramedic colleague from across the waters in Canada. He has written a fantastic blog post on Substack. He goes under the pseudonym of the paramedic philosopher. Today's blog post we're going to tackle is around EMS decision-making. Radu, welcome to the podcast.
Thanks for having me.
So Radu, this blog post is a fantastic piece. It was written in 2023. You talk to, there is no greater enemy to a paramedic than time. And just to that fundamental concept of slowing decision-making down sometimes, that almost rushing the decision-making process can actually work against a paramedic and or pre-hospital staff. And almost sometimes we do have to make rapid decision-making. And it is forced by the nature of the job. But actually, when we do have the opportunity, just slowing the process down, could I get you to kind of just really speak to why you wrote the blog?
For sure. Like all the articles that I write, a lot of them kind of are framed with what did we learn in school? How was our teaching given to us? And then how does it impact our practice and our way of thinking in the real world? And the EMS decision article was specifically because I feel there's this push, not just in school, but also in practice of you need to have the right answer right away. You need to be quick. And often that quick is expected to be instantaneous. And for a newer paramedic who has so much more to think about to a more seasoned paramedic who has such a more complicated patient in either an advanced care or a critical care dynamic, the rush to make the right answer or the right decision is often, I think, overdone. It's overstated. It becomes an excessive stress on the practitioner because they feel like if they don't have the answer as quickly as possible, or if their partner already happens to have the answer, they're falling behind, they're failing, so to speak, where the reality of the situation is there's often much more time to make a decision. There's often much more time to take a few extra seconds and say, well, my gut says this, but let me just double check a few things right away. You have time in almost all cases, and I obviously have to say almost because there are a few of those critical interventions, the deadly bleed, the lost airway, those kinds of situations where seconds will have a profound impact. A lost pulse. You don't have time to sit there for minutes and try to decide on what the correct answer is. You just have to act, and you just have to, keep circling that loop as much as you possibly can to get ahead of the disease process. But those are the profound exceptions to the rule. There is often time where we can sit there for 2 seconds and say, hey, this could be cardiac chest pain. This could be something else. I'm not sure I want to go down the cardiac chest pain route. Let's think about this for another couple of seconds, and then let's act on it. And unfortunately, it's hard for us to fight that instinct to quick and rapid reaction because in our schooling, our scenarios are they have to be very quick. You have 20 or 24 students. You cannot do a full scenario for every single student, with the time for them to actually prepare the resources that they talk about, to actually coordinate the things that they need to do. Rather than having every single student intubate, you'll say, well, I'm going to intubate the patient, I'm going to use this drug, this equipment, this and that. Okay, well, that's done. That's because we don't have time to talk about the rest of it. We need to move the scenario so that we can get a couple more in before the end of the day. And the damage that this has, I think, to paramedic mindsets and just their critical thinking and their way of operation is that they mistake just how much time some of these things take to actually decide in the real world, because scenarios are designed to be reasonably straightforward. They're designed to be reasonably approachable for all of the students, so that there's, you can kind of get the standard link from this to this to this, where in the real world it's often so much more gray. Do I actually need to intubate this person or do I not? Well, maybe 50-50. Maybe some people would, some people wouldn't. So it's about making sure you're able to make the decision that you need to make based on the equipment that you have, the practitioners that you have, the severity of the patient, the distance to a larger hospital that can support you, or some other extra set of hands that might be able to take some of the strain off the situation. And unfortunately for the scenarios, a lot of this stuff is not taken into account, and they need to see that you're decisive. They need to see that you can make these decisions when those important moments come. But we don't get that long-term time for knowledge to build or for things to actually take effect. So the perfect example is the fluid bolus for hypotension. And this actually just happened to me in the last few weeks, where we have a patient who is mildly hypotensive. In scenario land, okay, start a bolus. Well, in this scenario, they don't want the fluid to be the final answer. So they'll say there's no effect with the bolus. Okay, we'll give another bolus. There's no effect with that bolus either. It's amazing how quickly we've managed to infuse 500 mils or 1,000 mils into this patient just by saying another bolus, and for your instructor to say no effect. So it misses the time it takes to actually hook things up. It misses the time it takes to actually sit and do nothing and watch the drip, the drip, the drip, and actually see if the stuff that we're doing is having an effect. Where the scenario approach really quickly goes to, okay, well, we've hung up the bolus, there's been no effect, I need to move to the next thing. But no, there actually hasn't not been an effect yet, because we've just hung the bolus and the first few mils are just going in right now. So it's that ability to sit for certain things, or in certain cases, if we're concerned that the bolus actually won't be enough, having just started it, this is that moment to start prepping the rest of our gear, which again, in a scenario, isn't going to be developed, because you'll just say, okay, well, I'll just start a norepinephrine infusion. Okay, well, once again, in the interest of time, we don't have time for you to grab the vial, confirm the dose, properly mix it up, hook it up to the infusion pump, or if the situation calls for it, just a gravity drip, which unfortunately does still happen in certain situations. But it's having that understanding of how we actually need to decide when it comes to the patients that we're having to treat, because we also need to understand, I can't just say we need to intubate. I can tell the group, hey, we need to intubate, and we are going to be spending the next minimum 5, 10, 15 minutes putting all of our equipment together, getting ready to make this a success, rather than just, I intubate, I've got this, 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 and this, my backup is this, my gear is this, boom, it's done. Okay, moving on. Now I'm going to give another treatment. That works. No, it didn't. And also, how are we going to actually be able to make these decisions with, oh, well, it's me and my partner. No, we're not going to do any of that, because I need to be bagging this patient. My partner needs to drive the ambulance. Maybe nothing is going to actually happen, because we don't have time to do all the fancies, if the decision is there's something closer that would be more beneficial.
So one of the fantastic things you say within the piece, Radu, and I agree with this, is that OODA loops, so the observe, orientate, decide, and act, doesn't necessarily, moving quickly through that cycle doesn't necessarily benefit the practitioner or indeed the patient. And within OODA loops, as a as a one of many decision-making models, I've always found actually the orientation to be the most powerful piece of an OODA loop. So you observe, which is essentially, like you say, you're absorbing the information from the scene, from the patient, from your catalogue of injury lists that you've seen in the past or indeed learnt. But the orientation is the critical analysis pre-decision. And it is, to your point around, actually, are we going to go to the ceiling of our care? Because actually that's going to take a lot of logistical and maybe skill-based decisions and actions. Or are we going to maybe withhold those because we can actually maybe be a bit more conservative? Obviously, each situation mandates a different response, but that orientation and getting the room to help you orientate, I'm thinking A, B, and C. So thinking out loud, getting how am I missing anything? So almost resourcing the room for any other information that our finite nature can't understand. But you say within the piece that OODA loops are great, but they don't necessarily they serve the practitioner well when you need to maybe slow down a little bit, start to plan, start to assess, and start to think, do I truly need this level of intervention? Could I get you to speak to that?
Absolutely. As I mentioned in the article, the OODA loop was designed by specifically an Air Force doctrine um, officer, and it and it's most effective clearly in the manner for which it was designed. It has to be done fast in an aerial dogfight because those seconds will matter. You need to get ahead of your opponent. You need to constantly be cycling through because they're also conducting an OODA loop against you. So you need to have your OODA loop finished so that you can be a step ahead, because if they're halfway through theirs and you've just acted, well, now you're throwing theirs off because they have to start over again. They've observed and they've oriented themselves in one direction, but now you've reacted to that already. They need to start over. They're a step behind now. And if we think about it in the sense for a lot of EMS practitioners, there isn't that split second demand on our time. We have usually far more time than we think we have to observe, to orient, and then to finally make that decision. And in fact, the observe, orient, decide, and act is somewhat simplistic in a sense because we might observe, we might decide, we might then begin to orient our equipment in that direction. But that doesn't mean we don't also have to potentially redecide or reobserve or reorient as we go along the way. There's no requirement for us to finish our loop if something comes in the way for us to have to reset it. And I think that's the most important part about all of this is giving practitioners both a chance to take some time with their decision making, but also reach out to the resources nearby. So in our scenarios, we can't discuss it amongst ourselves because the instructor needs to see that each individual student can make these decisions based on the scenario's requirements. But then the second you get out into the real world, it very quickly becomes a collaborative effort. You can ask the nurses, you can ask the doctors, you can ask your partner, you can ask anybody who's around you for either information or for assistance if it's required, or assistance with whatever whatever observation might even be required. Hey, I think I heard this. Can you come and double check? Okay, they're hearing the same thing. We need to orient and decide our things a little bit differently now. And I think that's giving a little more flexibility and a little more openness when it comes to these processes, which unfortunately is very difficult to teach in school and still be able to say each individual student has the required skills if we're opening it up to a table discussion to make these decisions. So I don't know exactly how to kind of help break these ideas and these cycles without significantly complicating the education system, because we can't have full length scenarios. We can't have large collaborative discussions in the middle of some of these scenarios and still be able to say each student has kind of what it takes, even though in a lot of cases I'd rather have students that can ask their partners and cooperate rather than drive down a path because we need to teach them to be decisive. And this way you can have more of that collaborative effort of a coworker who's comfortable asking, hey, could we try this instead? Or another one to be able to say, hey, I have no idea what's going on. Do you mind stepping in, giving me an idea? Or, what would you do in this scenario? Kind of a situation. So we can create more of a kind of an open-minded and flexible approach to simplify decision making for each of us, but then also just make the process a lot easier for everybody along the way to collaborate, to cooperate, and to not feel like, well, if this is your attend, you have to do the OODA loops. Well, no, because maybe your partner is noticing something you're not because you're busy asking the patient questions. And it's and it fits reality, I think, a lot more closely than the scenario world does.
And I think it speaks to the wider piece, actually, Radu. We're just about to hear it in AI audio format, but I think I'd just like to absolutely come into land on this and just finally get your reflections, because you say, training really needs to mimic real world realities, and like you said, slowing things down. So okay, like you said, it's not just a verbal order, right? I'm going to now intubate the patient or give 250 ml bolus in scenarios, right? Okay, so I'm going to set the bag up. I'm going to run it through the giving set. Or I'm going to set the intubation kit up, because, like you said, that mimics and aligns to actually to real life. But also, to your point, Radu, going into these scenarios in training as a crew, actually in reality, like you say, you're able to turn around and go, Radu, what do you think? Because I'm not too sure. You should actually be able to do that in the scenario. Now, that's not to say it's a lack of competence. It actually mimics reality, because you never really, unless you're a first responder, you aren't an island. You have someone else in that room, and actually the being able to reflect that in training, and actually it's resourceful to turn around to you, or you turn around to me and go, what do you think and how would you do things? Because you're starting to the semblance of multidisciplinary team working, and actually you're starting to resource the second half of your brain, which is your other attending colleague. So it really does mandate that mimicry of what you see in scenarios into reality, and I'm a big believer in that, and even into the debrief.
I mean, I think we should be training how to fight. And um, that I think is kind of the biggest disservice we're doing our practitioners, because I mean, I remember when I first started, I felt like I had to make those decisions. I felt like my partner wouldn't be assisting me. Where, years into the practice, I'm starting to realize and constantly take advantage of the fact that while I'm performing my initial assessment of the patient, my partner doesn't have to. They don't have to listen to the information that's coming in from the patient or pay attention to the physical assessment that I am conducting. They can just sit there and look at the vitals. They can, take advantage of having a few seconds to just look around the scene. And even if they don't have any suggestions or observations of their own, they can often chime in with that one question that I forgot to ask, and the one that helps often make a bit of a difference in, oh, right, okay, no, we need to change our approach now because, that was one of the bigger questions. But in having to do all of the other tasks that I was doing, I got overloaded and missed one. And it's not a matter of, oh, I should remember that for next time I'm a bad practitioner. It's, oh, I had a lot more stuff to do. There's nothing wrong with turning to my partner who's not as task saturated, who's not as cognitively loaded, and they might be able to say, oh, we forgot to check this. It's right. Of course we should be checking that on this call. So yeah, there's something to be said for doing it fast, but I think 95% of the time we should be focusing on taking a little bit more time and doing it right.
Fantastic, fantastic. Listen, you're just about to hear the blog piece in audio format. You'll be able to click the link in the show notes and actually read the fantastic blog as well. Radu, it's always a pleasure. Thank you.
Thank you.
If you work in emergency response, you know that feeling, the sound of the clock ticking. It pretty much defines everything you do.
Oh, absolutely.
From the moment that call drops, you are just racing response times, assessment times, treatment times, transport times. We're trained, culturally and technically, that inaction is the enemy. You have to always be moving, always doing something.
And that urgency, well, it's often life-saving, definitely. But it pushes us towards this fundamental conflict, doesn't it? Which can sometimes be dangerous.
Yeah.
When the stakes are literally life and death, is the fastest treatment always, better than one that's maybe a bit slower, more deliberate, more precise?
That's exactly the tension we want to unpack today. We've been digging into some sources that look really closely at paramedic decision-making,
Right.
exploring what happens when that, deeply ingrained need for speed clashes head-on with the need for, accurate assessment. So our mission, really, is to find out if that professional sense of urgency is sometimes causing us to skip vital steps just to be fast. And what does that actually mean for patient care?
Yeah, and we're looking specifically at these decision models people use in high-pressure situations, like the OODA Loop.
Right, the OODA Loop.
And why applying them directly, sort of wholesale to complex human physiology might be, setting practitioners up to fail sometimes, forcing them to rush their expectations for what timely care actually looks like.
Okay, let's definitely unpack that core decision model then. The source immediately zeroes in on the OODA Loop. Observe, orient, decide, act. It's pretty legendary in scenarios needing rapid action and, for good reason.
Oh, totally.
The ability to cycle through those 4 phases really fast is usually a huge benefit.
It is, absolutely. But what's kind of fascinating here is where it comes from. The OODA Loop was literally designed by Colonel John Boyd for tactical maneuvers.
Okay.
Specifically for winning an aerial dogfight.
Wow, okay, a dogfight.
Yeah. So when your opponent is another jet, trying to shoot you down, the speed of your decision cycle is basically everything. The faster you cycle, the more you disorient the enemy, and, the higher your chance of survival.
So if we take that principle, that speed of cycling, and apply it to medicine, the enemy isn't another fighter jet. It's, a disease process.
Exactly. A heart attack, maybe a systemic infection, a major trauma. We have to adjust the timing based on how fast that enemy moves.
Right, makes sense.
And you have those clear-cut scenarios, the really high urgency ones, like, say, a cardiac arrest. In that situation, you are still kind of operating in the realm of a dogfight.
Okay.
Split-second reactions are absolutely needed, and every minute lost has a direct, measurable impact on brain function. Speed is everything there.
But the real focus of the source and what we're digging into is that huge gray area around those extreme cases.
Right. Think about a patient showing early signs of a stroke or maybe a severe infection like sepsis or even a really nuanced internal cardiac issue. These conditions are urgent, absolutely. But they don't typically crash in, 30 seconds. So the source raises this really critical question. What if we're sort of imposing that cardiac arrest mentality onto these grayer cases? What if we're rushing our own expectations for what a timely response actually is in those situations?
And what does that mean, practically speaking, for the paramedic, standing there at the bedside?
It means we might need to permit ourselves to invest a bit more time, maybe just an extra minute, maybe 90 seconds in that orient phase of the OODA Loop.
Orient, okay.
We need to do a better job defining the problem. We use this concept called differential diagnoses. It's just the medical term for making a mental list of everything that could be wrong with the patient.
Oh.
Ranking the possibilities and then systematically trying to rule things out.
So instead of just jumping to the quickest, most obvious fix, that extra minute of precision helps you really explore the competing explanations. Why does rushing that process, skipping the differential diagnosis, why does that create a problem?
Well, because a rushed diagnosis often leads to a rushed action that might be just slightly off target or maybe way off target. For instance, if you rush and mistake, say, a severe diabetic crisis for simple intoxication, your treatment's going to be completely wrong, possibly even harmful.
Right.
That minute you spend differentiating the two, orienting your resources, maybe confirming your hypothesis with a quick blood sugar check, that prevents a massive time sink later when the first treatment doesn't work.
Yeah.
So that small investment up front can yield a huge payoff down the line.
Okay, this is where it gets really interesting for me. If precision needs you to take that extra minute to orient, Where does that minute actually get spent in the workflow? It sounds like you're saying the Orient phase, the resource preparation part, is kind of the soft target that gets sacrificed first when we rush.
It absolutely is. The decide phase,
Yeah.
that's usually pretty fast. You observe the patient, you orient briefly, maybe too briefly, and you decide, okay, this patient needs treatment X. That's often the easy part. But the core problem that hits the practitioner out in the field is that the act phase isn't instant. It needs prep time. And that prep time really falls under Orient.
Can you give us a concrete example? Like, what procedure takes minutes to orient, even if the decision to do it takes seconds?
Oh, sure. Think about advanced airway management, like setting up for a potentially difficult intubation or preparing a complicated drug infusion. You might decide the patient needs, say, rapid sequence induction, RSI, in like 2 seconds flat. But preparing the specialized drugs, calculating the exact drip rates, checking the ventilator settings, physically getting all the equipment organized, that's the Orient phase. And that could easily take 3, maybe 5 minutes of focused, uninterrupted work.
And if you skip that sort of anticipatory orientation, those preparation minutes are now critically short because the patient is crashing right now and you're left scrambling.
Exactly. You're playing catch up just to execute the treatment you already decided on 5 minutes ago. You've lost crucial time, not necessarily during the assessment, but during the resource allocation. This lack of foresight, this inability to prepare for a need that you can see coming, it's a direct result of training that often just doesn't emphasize the duration or, frankly, the importance of that Orient phase.
Which brings us perfectly to the training environment itself. This whole issue of resource allocation seems compounded by how we actually teach and test decision-making. Why are training scenarios, whether they're simulated or live, why do they consistently suffer from these time restrictions?
Well, it's largely a logistical thing, unfortunately. In the real world, a full stabilization and transport might take 45 minutes, maybe an hour.
Right.
Now, if an instructor has a class of, say, 20 students, and each student has to run a full 45-minute scenario, well, you do the math. Testing the whole cohort would take days.
Yeah, impractical.
Totally impractical. So instructors compress time, but compressing time changes the fundamental nature of the critical thinking that's required.
Okay, so because of that logistical time crunch, what do these compressed scenarios inevitably end up focusing on?
They tend to zero in almost exclusively on the critical junctures, the dramatic moments.
Like the highlights reel.
Exactly. The patient's heart rate suddenly tanks, or they stop breathing, or maybe they just fail to respond to your initial treatment. Scenarios get structured as just a series of crises demanding immediate decisions. Bang, bang, bang.
But by focusing only on those dramatic junctures, we're completely missing the crucial period between them. The time required for effective monitoring and, crucially, orientation. It's like you said, watching only the climaxes of a movie, but skipping all the character development and buildup.
That's a perfect analogy, actually. We miss the boring but necessary middle part. The part where the patient might be stable-ish but slowly degrading, and where the practitioner should be silently working through potential complications and getting the resources ready for the crash that might be coming.
And this leads us straight to the biggest flaw the source points out.
Yeah.
This simulation shortcut and the way it distorts time. In a scenario, you give a drug, and almost immediately the instructor might prompt you.
Right.
With feedback like, okay, 5 minutes passed, no effect.
Yep, that's the simulation shortcut. And look, it's a necessary teaching tool in some ways, but it profoundly distorts the practitioner's sense of, let's call it professional patience.
Patience, okay.
In reality, waiting for a significant physiological change after giving a major drug like, say, an IV fluid bolus or an antiarrhythmic, that takes real minutes. You have to monitor, you have to reassess, you have to mentally prepare for the next possible step while you wait.
So the practitioner never really learns that essential skill of developing a tolerance for that waiting period.
Yeah.
They're basically trained that if the result isn't immediate, the plan has to instantly change.
Precisely. They're kind of deprived of the necessary time to actually process the failure of the initial treatment. Instead, they just move directly to the next, often frantic action. And this leads to what the source identifies as the most problematic outcome: the creation of a reactive mentality.
Okay, what does that reactive mentality look like out in the field?
It means the practitioner is sort of always waiting until they're prompted by the crisis itself. They wait for the patient's condition to actually drop before they even start thinking about getting the intubation supplies ready. They wait for the shock to return before they think about calling for a specific piece of equipment they might need. They acknowledge the issue only after it's become critical, and then they finally begin to orient a response. They're perpetually playing catch up.
Which sounds incredibly dangerous.
It is, especially when you're dealing with really critical patients where you have basically zero room for that kind of delay.
So they're letting the patient's deteriorating condition dictate their actions, rather than anticipating the next likely or even possible necessary step. If you're at a higher scope of practice, maybe managing a complex multi-system trauma, waiting until you're prompted to start preparing for the worst-case scenario means you probably already lost vital minutes.
Yeah, we're shifting here, aren't we? From the dogfight, OODA Loop to something maybe more like a chess game, particularly in those gray area cases we talked about.
Chess game, I like that.
If you're constantly just reacting to your opponent's last move in chess, you're almost certainly going to lose. You need to be thinking 2-3 moves ahead.
Right.
So the challenge then becomes, how do we structure our training environments to replace this reactive short-term focus with a more proactive, forward-thinking approach?
Okay, so the sources do offer some specific, pretty actionable recommendations for how to improve decision-making in practice. And it sounds like they focus entirely on fixing that Orient phase and promoting that professional patience you mentioned.
Exactly. The first solution directly tackles that time compression problem we discussed earlier. We need to design training environments that give students longer, more accurate scenarios.
Longer scenarios.
Yeah. And this isn't about just wasting time. It's about allowing practitioners the necessary space to conduct a full assessment, to actually put the diagnostic pieces together, and then formulate a solid plan at their own pace.
That idea of pace confidence seems huge.
Yeah.
It lets them internalize the value of that minute or two of precise planning. And the second solution you mentioned goes right back to that preparation deficit.
That's right. That's where we need to prioritize forward thinking. This basically means training practitioners to prepare equipment, supplies, even strategies for complications that may or may not actually happen.
Oh, okay.
You stock the airway box and double-check the monitor before the patient crashes. You prepare for the rapid transfer before you even confirm the final diagnosis that requires it.
So instead of waiting for that critical juncture to hit you, you're always trying to operate one step ahead, making sure the resources are physically there when the time finally comes to act.
Precisely. And this proactive approach, it accomplishes that necessary shift we need. It fundamentally integrates the preparation time into the assessment phase itself. It replaces that reactive mindset with a proactive one. It ensures that when you finally get to the decide phase, your subsequent act phase can be almost instantaneous because it's supported by fully prepared resources. That knowledge, knowing how long things actually take to set up, that's the true antidote to the frantic, sometimes counterproductive pace often celebrated in emergency response.
That really brings us full circle, doesn't it? This deep dive has effectively kind of redefined the concept of urgency in emergency care, or at least questioned it.
Yeah, I think so.
It highlights this vast difference between the split-second dogfight mentality, where rapid OODA cycling is king, and the sometimes slower reality of complex medical care, where maybe a minute of precise planning is often far more valuable than a rushed, potentially inaccurate reaction.
The value of preparation and developing that professional patience, it's just undeniable, even in a field that's so defined by speed. This analysis really demonstrates that sometimes the most effective action you can possibly take is the preparation that happens silently, proactively, before the critical juncture even hits.
We do often celebrate those who rush in, don't we? Those heroes who make the chaotic split-second decision under pressure.
We do. But maybe based on this analysis, we should ask ourselves, what common professional or even personal scenarios in your own life might actually benefit from deliberately slowing down that Orient phase instead of just rushing directly to act?
Interesting question.
Maybe it's a difficult conversation you need to have. Maybe it's prepping for a big presentation, or maybe it's even something like a financial plan. What situation are you currently rushing through where just an extra minute or two of precise preparation and resource orientation could fundamentally change the outcome for the better? Something for all of us to think about, I suppose, as we cycle through our own decisions every day.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.